Dear students, today we discuss a very broad subject concerning physiological changes of aging, major geriatric syndromes, and pharmacotherapy in older adults. First, just a quick review of demographic aspects. The demography of all countries has changed rapidly in recent decades. The number of people aged 60 and more years old is increasing rapidly. As you can see, this diagram is showing us the percentage of population aged 60 plus years in 2012 and its predicted number in 2050. For example, in 2012, for Russian Federation, this number was around 10 to 20%. For India, it was up to 10%. And it is predicted that by 2050, percentage of population aged 60 years and more will be increased more than 30% in Russian Federation, and in India it will be around 10 to 20%. The number of people aged 60 years or older will rise from 900 million to 2 billion between 2015 and 2050, moving from 12% to 22% of the total global population. Population aging is happening more quickly than in the past. A longer life represents an important opportunity, not only for older people and their families, but also for societies as a whole. Additional years provide the chance to pursue new activities while continue to make valuable contributions to family and community. Yet, the extent of these opportunities depends heavily on one factor: health. Now, moving on to biology of aging. Aging can be defined as a progressive accumulation through life of random molecular defects that build up within cells and tissues. Eventually, and despite multiple repair and maintenance mechanisms, these result in age-related functional impairment of tissues and organs. The aging process is driven by a lifelong accumulation of molecular damage, resulting in gradual increase in the fraction of cells carrying defects. After sufficient time has passed, the increasing levels of these defects interfere with disease. Stress, adverse environment, and poor nutrition can increase the rate at which molecular damage arises. Intrinsic maintenance mechanisms such as DNA repair and antioxidants, as well as healthy lifestyle and favorable environment, can slow the rate of accumulation. Human life expectancy depends on various factors. As you can see on the diagram, genetic factors account only for 10% of the variance in human lifespan. However, social factors and health behaviors, which mean lifestyle, determine most of the rest, see like 40 and 30%. The mechanisms of aging. At a cellular level, production of reactive oxygen species is thought to play a major role in aging. These molecules cause oxidative damage at a number of targets. First of all, nuclear chromosomal DNA, causing mutations and deletions that ultimately lead to aberrant gene function and potential for malignancy. Then telomeres, the structures and the ends of chromosomes that shorten with each cell division, because telomerase is absent in somatic cells. When telomeres are sufficiently eroded, cells stop dividing. The next is mitochondrial DNA and lipid peroxidation, resulting in reduced cellular energy production and ultimately cell death. and proteins, especially those that are modified by glycosylation due to spontaneous reactions between proteins and sugars. These damage structures and function of the affected protein, which becomes resistant to breakdown. The rate at which damage occurs is variable, and this is where the interplay with environment and particularly lifestyle habits takes place. Normal changes affects all physiological processes. Subtle irreversible changes in the function of most organs can be shown to occur by the fourth decade of life, with progressive deterioration with age. Physiologic changes in central nervous system include neuronal loss, cochlear degeneration, increased lens rigidity, lens ossification, anterior horn sand loss, dorsal column loss, slowed reaction times. And the clinical consequences of these changes are increased risk of delirium, presbycusis, high-tone hearing loss, presbyopia, abnormal near vision, cataract, reduced position and vibration sense, increased risk of falls. Physiological changes in respiratory system include reduced lung elasticity and alveolar support, increased chest wall rigidity, increased ventilation perfusion mismatch, reduced cough and ciliary action. This will lead to reduced vital capacity and peak expiratory flow, increased residual volume, reduced inspiratory reserve volume, reduced arterial oxygen saturation, increased risk of infection. Physiological changes in cardiovascular system include reduced maximum heart rate, dilation of aorta, reduced elasticity of blood vessels, reduced number of pacing myocytes in sinoatrial node. These may lead to such consequences as reduced exercise tolerance, widened aortic arch, increased risk of postural hypertension, increased risk of atrial fibrillation. Physiological changes in renal system include loss of nephrons, reduced glomerular filtration rate, reduced tubular function, and the clinical consequences with aging will be impaired fluid balance, increased risk of dehydration or overload, impaired drug metabolism and exertion. Physiological changes in endocrine systems are mostly deterioration in pancreatic beta cell function that may lead to increased risk of impaired glucose tolerance and to diabetes mellitus. As for gastrointestinal system, it is reduced motility that most frequently causes constipation. Physiological changes in bones and muscles include reduced bone mineral density, loss of type 2 muscle fibers, and reduction in muscle satellite cell numbers. Due to this, with aging, there is increased risk of osteoporosis and fracture, muscle weakness, and increased risk of falls. Now, the next major topic we are going to discuss is geriatric syndromes. Geriatric syndrome is the term used to describe a group of common health conditions in older people that do not fit into discrete disease categories. Geriatric syndrome is a multifactorial age-associated clinical condition that worsens quality of life, increases the risk of adverse outcomes such as death, dependence on outside help, readmissions, need for long-term care, and functional impairment. The major geriatric syndromes include a number of conditions typical of, if not specific to, aging, such as dementia, depression, delirium, falls, frailty, sleep disorders, syncope, pressure ulcers, urinary incontinence, spontaneous bone fractures, malnutrition, polypharmacy. Geriatric syndromes are associated with reduced life expectancy. The major and the first geriatric syndrome we will discuss is frailty. Frailty is a clinical state of increased vulnerability and decreased ability to maintain homeostasis that is characterized by declines in functional reserves across multiple physiologic systems. It is not age-dependent and can also occur in younger people, although incidence and prevalence increase with advancing age. The concept of frailty overlaps but is not completely identical to the concepts of comorbidity or disability. Whereas comorbidity refers to presence of other health states or conditions, usually two or more medical conditions. Examples include hypertension and diabetes, or chronic coronary syndromes and hypothyroidism. Disability refers to need for assistance from others to accomplish various tasks. An example would be the need to have someone help with bathing, dressing, or using the toilet. So it means the difficulty or dependency in daily living activities. Geriatric medicine has found the concept of frailty compelling for several reasons. First, frail individuals are at highest risk for a number of adverse health outcomes, including medical instability, disability and dependency, institutionalization, injuries, falls, acute illness, hospitalization, healthcare resources utilization, slow or incomplete recovery from illness and or hospitalization. Additionally, they have compromised ability to tolerate hospitalization or invasive procedures and are at high risk of iatrogenesis and side effects from medical intervention. And due to this, they're at high risk of mortality. Given the marked vulnerability to adverse health outcomes of those who are frail, it is critically important to have clinically valid approaches to recognizing frailty. This would provide a basis for incorporating intentional approaches to prevention and treatment of frailty into clinical care. To date, there are several approaches that have been developed to identify those who are frail. First of all, it is a clinical frailty scale, which is a 9-point clinical assessment tool designed to assist healthcare professionals in evaluating a person's frailty status across various clinical settings. It serves to assist clinicians in identifying frailty, risk stratifications, and guide clinical management. According to clinical frailty scale, a healthcare practitioner asks a patient or relative about presence of any terminal illness, for example, the presence of terminal cancer with less than 6-month prognosis. If the patient or relative answers yes, this is a clinical frailty scale category terminally ill. If the answer is no, the next question will be if the patient is dependent in all basic daily living activities. If the patient is dependent, the next question is, would you be surprised if the patient passes on in less than 6 months? If the question is no, this is very severely frail patient. If the question is yes, this is a category of severely frail. Now, if the patient is not dependent in all basic activities of daily living, the next question is whether the patient is assistant in 1 to 5 basic activities of daily living. If the question is yes, if the answer is yes, this is meaning that this is a moderately frail patient. If the answer is no, the next is if the patient is independent in all basic activities of daily living, but assisted in more than one instrumental activities of daily living. Again, if the answer is yes, this is a mildly frail patient. If the answer is no, the next question is the appearance, the presence of chronic medical condition that requires medication. If yes, the next question, symptoms limit usual activity or feels slowed down. If yes, this is a pre-frail patient, a vulnerable patient. If no, the patient is managing well. And the last question, if the patient exercises regularly and or appears fitter compared to someone their own age. If the answer is no, this is the score of well. If yes, this is a very fit patient. Here you can see the list of basic activities of daily living, which include dressing, eating, evacuation, ambulation, toileting, and hygiene. And the list of instrumental activities of daily living, including shopping, housekeeping, accounting, food preparation, transportation, and taking medications. A clinical frailty scale includes 9 categories that are very fit. First category is very fit. These are people who are robust, active, energetic, and motivated. These people commonly exercise regularly. They're among the fittest for their age. The second group is well. People who have no active disease symptoms but are less fit than category 1. Often they exercise or are very active occasionally, like seasonally. The third group is managing well. people whose medical problems are well controlled but are not regularly active beyond routine walking. Group 4 is vulnerable. While not dependent on others for daily help, often symptoms limit activities. A common complaint is being slowed up and or being tired during the day. The fifth is mildly frail. These people often have more evidence slowing and need help in high-order instrumental activities of daily living like finances, transportation, heavy housework, medications. Typically, mild frailty progressively impairs shopping and walking outside alone, meal preparation, and housework. The next is moderately frail. People need help with all outside activities and with keeping house. Inside, they often have problems with stairs and need help with bathing and might need minimal assistance, queuing, standby, with dressing. Group number 7 is severely frail. These are completely dependent for personal care from whatever cause, physical or cognitive. Even so, they seem stable and not at high risk of dying within next 6 months. Group 8 is very severely frail, completely dependent, approaching end of life. Typically, they could not recover even from a minor illness. And group 9 is terminally ill. These people approaching the end of life. This category applies to people with a life expectancy less than 6 months who are not otherwise evidently frail. The stages 1 to 3 and 7 to 8 in the final rating result in 5 categories. The category robust stages from 1 to 3. Category vulnerable is stage 4. Mildly frail is 5. Moderately frail 6. And severely frail categories 8 and 9. Another assessment scale requires a healthcare practitioner to weight a patient, measure grip strength and walking speed, and to ask 2 questions regarding exhaustion and the physical activity questionnaire. The patient is considered frail if having 3 or more frailty components, pre-frail if having 1 or 2 frailty criteria, and non-frail if having none criteria. Measurements of walking speed and possibly strength are considered geriatric vital signs and should be assessed regularly in clinical settings. The next geriatric syndrome is delirium. It is defined as an acute disorder of attention and global cognitive function and is a common, serious, and potentially preventable source of morbidity and mortality for hospitalized older adults. It occurs in 14 to 56% of elderly and represents the most frequent complication of hospitalization for this group. The standardized criteria for delirium that appear in the American Psychiatric Association's Diagnostic and Statistical Manual of Mental Disorders include a disturbance of consciousness with reduced ability to focus, sustain, or shift attention. The next, a change in cognition, such as memory, deficit, disorientation, language disturbance, or the development of perceptual disturbance that is not better accounted for by pre-existing dementia. The disturbance develops over a short period of time, usually hours to days, and tends to fluctuate over the course of a 24-hour period. Evidence from the history, physical examination, or laboratory findings that the disturbance is caused by an underlying organic condition or is the direct physiological consequences of a general medical condition or its treatment. A standardized tool, the confusion assessment method, provides a brief, validated diagnostic algorithm that is currently in widespread use for identification of delirium. The confusion assessment method algorithm relies on the presence of acute onset and fluctuating course, inattention, and either disorganized thinking or altered level of consciousness. Feature 1 includes acute onset and fluctuating course. This feature is usually obtained from a reliable reporter, such as a family member, caregiver, or nurse, and is shown by positive responses to these questions. Is there evidence of any acute change in mental status from the patient's baseline? Did the abnormal behavior fluctuate during the day, that is, tend to come and go, or did it increase and decrease in severity? Feature 2, inattention. This feature is shown by a positive response to this question. Did the patient have difficulty focusing attention, for example, being easily distractible or having difficulty keeping track or what was being said? Feature 3, disorganized thinking. This feature is shown by a positive response to this question. Was the patient as thinking disorganized or incoherent, such as rambling or irrelevant conversation, unclear or illogical flow of ideas, or unpredictable switching from subject to subject? And feature 4, altered level of consciousness. This feature is shown by an answer other than alert to this question. Overall, how would you rate this patient's level of consciousness? Either alert or normal, or vigilant, hyper alert, or lethargic, drowsy, easily aroused, or stupor, difficult to arouse, or coma, unarousable. The diagnosis of delirium by confusion assessment method requires the presence of feature 1, feature 2, and of either feature 3 or 4. Or like here you can see feature A, B, C, and D. The ratings for the confusion assessment method should be completed following brief cognitive assessment of the patient. For example, the easiest tool is the mini mental state examination. This is a 30-point questionnaire that is used extensively in clinical settings to screen and estimate the severity of cognitive impairment. It includes questions about orientation, memory, attention and calculation, language and praxis. Each one of the questions gives points, and the total score of 24 to 30 points means no cognitive impairment. The score from 19 to 23 points gives us mild cognitive impairment. Score 10 from 18 is moderate cognitive impairment, and 0 to 9 is severe cognitive impairment. The etiology of delirium is usually multifactorial. Like many other common geriatric syndromes such as falls, incontinence, and pressure sores, delirium usually results from the interrelationship between patients' vulnerability, which are predisposing factors, and the occurrence of noxious insults that are precipitating factors. For example, patients who are highly vulnerable to delirium at baseline, such as patients with dementia or severe illness, can experience acute delirium after exposure to otherwise mild insults, such as a single dose of a sedative medication for sleep. On the other hand, older patients with few predisposing factors that have low baseline vulnerability would be relatively resistant, with a precipitation of delirium only after exposure to multiple potentially detrimental insults, such as general anesthesia, major surgery, multiple psychoactive medications, immobilization, severe infection. Predisposing factors for delirium include pre-existing cognitive impairment or dementia, advanced age, severe underlying illness and comorbidity, functional impairment, male gender, depression, chronic renal insufficiency, dehydration, malnutrition, alcohol abuse, sensory impairments like vision or hearing. Pre-existing cognitive impairment or dementia is a powerful and consistent risk factor for delirium, demonstrated across multiple studies, and patients with dementia have a 2 to 5-fold increased risk for delirium. Moreover, up to half of delirious patients have underlying dementia. Nearly any chronic medical condition can predispose to delirium. Now, major precipitating factors, which are noxious insults, include medication use, immobilization, use of indwelling bladder catheters, use of physical restraints, dehydration, malnutrition, iatrogenic events, medical illnesses, infections, metabolic derangements, alcohol or drug intoxication or withdrawal, environmental influences, and psychosocial factors. Decreased mobility is strongly associated with delirium and concomitant functional decline. Many of these events potentially are preventable. Clinically, the overall importance of the multifactorial nature of delirium is that removal or treatment of one risk factor alone often fails to resolve delirium. Instead, addressing many or all of the predisposing and precipitating factors for delirium is often required before the delirium improves. In 40% or more of delirium causes, use of one or more specific medication contributes to its development. While medications often incite delirium, they are also the most common remediable cause of delirium. A broad array of medications and their metabolites can lead to delirium. The most common are those with known psychoactive effects, such as sedatives or hypnotics, anxiolytics, narcotics. The other ones include anticholinergics like antihistamines, antispasmoids, cardiac drugs such as digitalis glycosides, antiarrhythmics like quinidine, procainamide, lidocaine, some antihypertensives such as beta blockers and methyl-dopa, and gastrointestinal drugs like histamine antagonists, ranitidine, famotidine, proton pump inhibitors, metoclopramide, and some herbal remedies such as valerian root, very commonly used among the elder adults. The next major geriatric syndrome we are going to discuss is falls. Falls are common in older adults. A fall injury is costly in terms of morbidity, loss of physical function, independence, and mortality. Approximately 35% to 40% of persons aged 65 years and over fall in a given year. Half of persons who fall do so more than once. The incidence increases steadily after age 60 years. Approximately 50% of persons aged 80 years and older fall in a year. Women are more likely to fall than men. Falls account for 87% of all fractures and for more than 95% of hip fractures in older adults. Falls are the second leading cause of brain and spinal cord injury in older adults. Prospective and retrospective community and nursing home-based studies in the past 15 years have identified a number of factors that increase an older person's risk of falling. Age greater than 80 years, need for assistance with activities of daily living, and previous falls increase the risk for future falls. While these characteristics cannot be modified, they serve as indicators for clinicians to pay increased attention to the presence of other treatable risk factors for falls. The most important modifiable intrinsic risk factors for falls are gait and balance deficit, strength, visual deficit, arthritis, depression, and cognitive impairment. The next geriatric syndrome is syncope. Syncope is a symptom defined as a transient, self-limited loss of consciousness, usually leading to falling. The temporary cessation of cerebral function that causes syncope results from transient and sudden reduction of blood flow to parts of the brain, like brainstem reticular activating system, responsible for consciousness. Multifactorial etiology most likely explains the majority of cases of syncope in older persons who are predisposed because of multiple chronic diseases and medications effects superimposed on the age-related physiologic changes. Medications that may contribute to or cause syncope are listed in the table. These are, first of all, diuretics. The mechanism that they act, due to the volume depletion. The other are vasodilators like angiotensin converting enzyme inhibitors, calcium channel blockers, hydralazine nitrates, alpha-adrenergic blockers. They reduce the systemic vascular resistance and lead to venodilation. Others are antiarrhythmic drugs like amiodarone, quinidine, procainamide, cetalol, digoxin, disopyramide, flecainide. They may cause other cardiac arrhythmias, and some of them are associated with prolonged QT interval and ventricular tachycardias. The psychoactive drugs like tricyclic antidepressants, phenothiazines, monoamine oxidase inhibitors, barbiturates, they may cause again cardiac arrhythmias, and they may cause hypertension. And also alcohol. Alcohol affects the central nervous system, causing hypertension, and may also have pro-arrhythmogenic effect. Common causes of syncope are listed on this slide. The most frequent individual causes of syncope in older patients are neurally mediated syndromes, including carotid sinus syndrome, orthostatic hypotension, and postprandial hypertension, as well as arrhythmias, including both tachyarrhythmias and bradyarrhythmias. Also, very frequently we see implanted device malfunction like pacemaker malfunction, or structural cardiac or cardiopulmonary diseases like cardiac valvular disease, acute myocardial infarction or ischemia, acute aortic dissection, pericardial disease, tamponade, pulmonary embolus, or pulmonary hypertension. Disorders that may be confused with syncope and that may or may not be associated with loss of consciousness are transient ischemic attacks of carotid or vertebra-basilar origin, hypoglycemia and other metabolic disorders, some forms of epilepsy, alcohol and other intoxications, and hyperventilations with hypocapnia. It's important to distinguish these disorders and to treat them. Now, the next geriatric syndrome is incontinence. Incontinence is defined as the complaint of any involuntary leakage of urine. Urinary incontinence is a common and bothersome condition in elderly persons. The prevalence of incontinence increases with age and with increasing frailty, and is 2 times greater in older women than in older men. Many older people who do not leak urine still may have bothersome lower urinary tract symptoms such as urgency, frequency, and nocturia. Urinary incontinence can be cured or greatly improved, especially in those who have adequate mobility and mental functioning. Even when not curable, incontinence can always be managed to allow for more patient comfort, make life easier for caregivers, and minimize cost of caring for the condition. Because many elderly patients are embarrassed to discuss their incontinence and may not be aware that treatment is available, it is essential for specific questions about incontinence to be included in periodic assessment and for incontinence to be noted as a problem. These questions. Yes, the general practitioner always has to ask specific questions about urinary incontinence. These questions should be open-ended and phrased in language easily understood by the patient. So the examples of the questions may be: tell me about any problems you are having with your bladder, or tell me about any trouble you are having holding your urine. If the responses to the above questions are negative, following up with questions may be helpful. How often do you lose urine when you don't want to? Or how often do you wear a pad or other protective device to prevent urinary accidents? Continence requires effective functioning of the lower urinary tract, adequate cognitive and physical functioning, motivation, and an appropriate environment. Anatomic and physiologic aspects of the lower urinary tract, as well as functional, psychological, and environmental factors, contribute to the pathophysiology of incontinence in older adults. The distinction between acute for reversible forms of incontinence and persistent or established incontinence is clinically important, although not always distinct. Acute incontinence refers to those situations in which the incontinence is of sudden onset, usually related to an acute illness or an iatrogenic problem, and subsides once the illness or medication problem has been resolved. Persistent incontinence refers to incontinence that is unrelated to an acute illness and persists over time. The potentially reversible causes of urinary incontinence are listed on this table. These causes include conditions affecting the lower urinary tract, like urinary tract infection, atrophic urethritis, vaginitis, post-prostatectomy, and stool impaction. And these conditions can be managed. The infections can be managed with antimicrobial therapy. The atrophic conditions are well managed with topical estrogens. The prostatectomy, after prostatectomy, there is a need for behavioral interventions and avoiding further surgical therapy until it is clear condition will not resolve. And for stool impaction, there is the need for disimpaction, appropriate use of stool softeners, bulk forming agents, and laxatives if necessary. The implements with high fiber intake, adequate mobility, and fluid intake. The other conditions include increased urine production, like metabolic, which is hyperglycemia or hypercalcemia, excess fluid intake, volume overload, or venous insufficiency with edema. The management will include better control of diabetes mellitus. First of all, therapy for hypercalcemia depends on underlying cause. reduction in intake of diuretic fluids like the caffeinated beverages, and for the edema, leg elevation, sodium restriction, and diuretic therapy. Diuretics by itself can lead to the urine incontinence and leakage, so sometimes there is a need for discontinuing and changing of the therapy if it is clinically appropriate. The other conditions include congestive heart failure, impaired ability or willingness to reach a toilet, psychological factors like delirium or dementia, chronic illnesses or injuries that interferes with the mobility of patient, which will need the help of family or caregivers with a regular toileting. There are a lot of medications that can potentially affect continence. Some of them you can see on this slide. As example, diuretics have potential effect of polyuria, frequency and urgency. Anticholinergics may cause urinary retention, overflow, incontinence and stool impaction that also affects the urine retention. Antidepressants, antipsychotics, sedative hypnotics, they have the anticholinergic action, sedation, they may lead to immobility and urethral muscle relaxation. The narcotic analgesics as well may cause urinary retention, fecal impaction, sedation and delirium. Alpha-adrenergic blockers may lead to urethral relaxation. Angiotensin converting enzyme inhibitors that are broadly used for hypertension may have a side effect of cough, precipitating stress incontinence. Beta-adrenergic agonists rarely may contribute to urinary retention, as well as calcium channel blockers. These drugs are widely used in hypertension and in chronic coronary syndrome patients. Alcohol may lead to polyuria, frequency, urgency, sedation, delirium, and in some cases to immobility. And caffeine use always leads to polyuria and bladder irritation. And moving on to our next topic is pharmacotherapy in older adults. The most common intervention performed by physicians is to write a prescription. Older patients have more conditions requiring medication, and polypharmacy is common. Polypharmacy is a term indicating the use of multiple medications. The exact number of medications that constitutes polypharmacy is variable, ranging from 3 to 5 in some studies and to 9 medications. Consequences of polypharmacy include increased risk of medication non-adherence, adverse drug reactions, drug interactions, geriatric syndromes, the ones that we discussed like falls, urinary incontinence, cognitive impairment, and increased healthcare costs. Risk factors for polypharmacy include, first of all, increased age. With increased age, the patients usually have multiple pathology, or we call it comorbidity. Poor patient education, lack of routine review of all medications, overuse of drug interventions by doctors, attendance at multiple specialist clinics, and poor communication between specialists. Good prescribing habits are essential for any medical practitioner. There are some important rules of prescribing that are especially true when prescribing for older adults. Please pay attention to these rules. First, before starting a medication, you as a practitioner have to always consider the following question. What is the diagnosis? Is it indicated? Yes, for example, maybe the symptom of the patient, like dizziness, is due to postural blood pressure drop. Now, can something be stopped, like opioid analgesia causing constipation? And are there any non-drug measures? As example, to increase fiber for constipation. The second major rule and major question, are there any contraindications? Before administering a drug, always review past medical history. Third, are there any likely interactions? So you always have to review the medication list that the patient is already taking and pay attention if there are any serious drug interactions. Fourth, what is the best drug? It's better to choose the broad category of drug. As example, when you're choosing the antihypertensive, by considering which one will work best in this particular patient, like angiotensin converting enzyme inhibitors work less well in African Americans, or which is least likely to cause side effects. As example, calcium channel blockers may worsen lower extremity edema in elder adults. And if there is any potential for a dual action, as an example, a patient with angina, stable angina, could have a beta blocker for both, for angina and for blood pressure control. The fifth question is what dose should be started? Here we usually use the rule start low and go slow. Drugs in older adults are usually better tolerated at lower doses and can be increased if there are no adverse reactions. So you always need to follow up the patient, and when you start, as an example, antihypertensive drug, ACE inhibitor or beta blocker, you better start with a lower dose, and then with a follow-up in several weeks, you may increase the dose if the drug is well tolerated. The sixth rule, how will the impact be assessed? This is what I already told you, yes? You schedule follow-up, looking for the following, the efficacy of the drug, because if it's not effective, we change the drug, the important side effects, and the capacity to increase the dose. And the last but not least, what is the time frame? Many older adults must remain on medication for a long time. If so, the patient should be aware of this and continue to refill the prescription, because some of the patients don't understand that they have to take their medications for a lifelong time. Some of them use the antihypertensive drugs for 1 month and then discontinue. So this is your job as a physician, as a general practitioner, to remind the patient to take their medicines for as long as it needed and to refill the prescription. On the contrary, some drugs should not be prescribed long term. Medications should be regularly reviewed and discontinued if ineffective or no longer indicated. As an example, some psychotropic medications that may contribute to falls and frailty. The administration challenges in older adults may include the following. First of all, packaging may make tablets hard to access, like child-proof bottles and tablets in blister packets that can be difficult to open with arthritic hands or poor vision. For this case, the patient might need some assistance. The second, the labels may be too small to read with visual impairment. Now, the next, tablets may be large and difficult to swallow or have an unpleasant taste. Liquid formulations can be useful in this case, but accurate dosage becomes harder to maintain, and not all the medications have the liquid forms. Any tablet needs around 60 milliliters of water to wash it down and prevent adherence to the esophageal mucosa, which is a large volume for some patients, so you might consider this. Regimens of multiple tablets with different instructions, some of them needs to be taken before, some of them after meals, some of them in the morning, some of them in the afternoon or in the evening. These are very confusing and may be taken in a suboptimal way. Some routes may be impossible without assistance, like, for example, the topical route that should be applied to the back. It's usually hard to do by oneself. Pharmacodynamics of the drugs in older patients. First of all, absorption. Many factors are different in older patients. The increased gastric pH, delayed gastric emptying, reduced intestinal motility and blood flow. Despite this, absorption of drugs is largely unchanged with age. Exceptions include iron and calcium supplements, which are absorbed more slowly. Their distribution. Some older people have a very low lean body mass. So if the therapeutic index for a drug is narrow, such as digoxin, the dose should be adjusted. There is often an increased proportion of body fat compared with that of water. This reduces the volume of distribution for water-soluble drugs, given a higher initial concentration, again, such as digoxin. It also leads to accumulation of fat-soluble drugs, prolonging elimination and effect. And there is reduced plasma protein binding of drugs with age, which increases the free fraction of protein-bound drugs such as warfarin and furosemide. The changes in hepatic metabolism in elderly. Specific hepatic metabolic pathways such as conjugation are usually unaffected by age. A reduced hepatic mass and blood flow with a right-sided congestive heart failure, for example, can affect overall function, which slows metabolism of drugs such as theophylline, acetaminophen, diazepam, nifedipine. Drugs that undergo extensive first-pass metabolism, such as propranolol or nitrates and many others, are most affected by the reduced hepatic function. Many factors interact with liver metabolism. These factors are the nutritional state of patient, acute illness, smoking, the use of other medications. Patients with congestive heart failure can develop hepatic congestion, which leads to impaired hepatic metabolism of some drugs. What about the renal function and renal exertion of drugs in elderly? Renal function usually declines with age, which has a profound impact on the elimination of drugs that are predominantly handled renally. Renal mass declines by 20 to 25% from age 30 to 80. Glomerular filtration rate, measured by creatinine clearance, decreases by approximately 10% per decade of life after age 30. When assessing renal function in elderly patients, do not be misled by a normal serum creatinine. Please pay attention to this. Because of low muscle mass with resultant decreased production of creatinine, an elderly patient with normal serum creatinine may have severe renal dysfunction. Due to this, always estimate creatinine clearance, glomerular filtration rate. It is very easily estimated. There are a lot of online calculators that may be used on your phones, so do not forget to count the glomerular filtration rate. In general, when creatinine clearance is less than 60 milliliters per minute, the dose adjustment is necessary. Most of the drugs need the adjustment of the dose with a lower glomerular filtration rate, like less than 30 milliliters per minute, but you have always to check this important cause. Drugs or drugs with active metabolites that are mainly excreted by the kidney include allopurinol, digoxin, furosemide, gabapentin, gentamicin, lithium, metformin, ranitidine, tetracyclines, and many other drugs frequently used in elder adults. Where there is a narrow therapeutic index, again like digoxin or some antibiotics like aminoglycosides, then dose adjustment for renal impairment is required. Impaired renal function is exacerbated by dehydration and urosepsis that are very common in older patients. The next very important aspect is how to improve adherence in older adults. First of all, for you as a general practitioner, there is a need to simplify prescription regimens. This is converting to once-a-day dosing where possible, trying to prescribe medications to be taken at the same time of day, trying to use medications that have dual indications for the patient. As the example I already told, beta blockers, they have dual indication for angina and for hypertension as well, yes? Optimizing the dose of one medication before switching to or adding another agent. Yes, remember, we're starting with a low dose and then gradually increasing the dose. And only after that, after adjusting the dose, we will add another agent if it's not effective. And considering a daily dose reminder system, like a pill box or a monitored dosage system. The next is educate the patient and family. You have to make sure that the family and the caregiver and the patient by himself understands the reason for taking the medication and understands how to take this medication correctly. Medication summaries can assist with it. You have to warn of predictable side effects that are likely to pass. It is important to promote personal responsibility for medication. And usually some caregivers or family should check pill boxes and see if the medications are actually being taken. Now, the drug interaction mechanisms. Frailty and multiple diseases make drug disease interactions more common. A drug interaction occurs when the administration of one drug increases or decreases the beneficial or adverse responses to another drug. Although the number of potential interacting drug combinations is very large, only a small number are common in clinical practice. Important drug interactions are most likely to occur when the affected drug has a low therapeutic index, steep dose response curve, high first pass or saturable metabolism, or a single mechanism of elimination. Pharmacodynamic interactions occur when two drugs produce additive, synergistic, or antagonistic effects at the same drug target, receptor or enzyme as example, or physiological system like electrolyte, exertion, heart rate. Pharmacokinetic interactions occur when the administration of a second drug alters the concentration of the first at its site of action. There are numerous potential mechanisms: absorption interactions, drugs that either delay or enhance gastric emptying, influence the rate of rise in plasma concentration of other drugs, but not the total amount of drug absorbed. Drugs that bind to form insoluble complexes or chelates like aluminum containing antacids binding with ciprofloxacin can reduce drug absorption. The distribution interactions, which are co-administration of drugs that compete for protein binding in plasma, such as phenytoin and diazepam as example, can increase the unbound drug concentration, but the effect is usually short-lived due to increased elimination and hence restoration of the pre-interaction equilibrium. Now, metabolism interactions. Many drugs rely on metabolism by different enzymes of cytochrome. P450 in the liver. Cytochrome enzyme inducers generally reduce plasma concentrations of other drugs, although they may enhance activation of prodrugs. Cytochrome enzyme inhibitors like clarithromycin, cimetidine, grapefruit juice have the opposite effect. And excretion interactions. These primarily affect renal exertion. For example, drug-induced reduction in glomerular filtration rate, like diuretic-induced dehydration, angiotensin-converting enzyme inhibitors, non-steroid anti-inflammatory drugs, can reduce the clearance and increase the plasma concentration of many drugs, including some with a low therapeutic index. Some of the common drug interactions are pictured on this slide. For example, the chemical reaction between the sodium bicarbonate and calcium gluconate can result in precipitation of insoluble calcium carbonate. The mechanism of reduced absorption, the interaction of tetracyclines with calcium, aluminium, and magnesium salts may lead to reduced tetracycline absorption. The reduced metabolism by cytochrome enzymes, yes, the interaction of amiodarone with grapefruit juice can lead to increased level of amiodarone in blood and as a result to prolonged QT interval on a ECG and the risk of fatal cardiac arrhythmias. The interaction between warfarin and clarithromycin may lead to enhanced anticoagulation and the high risk of bleeding. The interaction between catecholamines and monoamine oxide inhibitors may lead to hypertensive crisis due to monoamine toxicity. The reduced renal elimination of methotrexate together with non-steroid anti-inflammatory drugs may lead to methotrexate toxicity. The direct potentiation in same organ system, as an example, AC inhibitors and non-steroid anti-inflammatory drugs, their interaction may cause the increased risk of renal impairment. The indirect potentiation by action in different organ systems, like the use of digoxin together with diuretics, may lead to hypokalemia and increased digoxin toxicity. The interaction of warfarin with aspirin and other non-steroid anti-inflammatory drugs may lead to increased risk of bleeding because of gastrotoxicity and antiplatelet effects. And the interaction between diuretics with AC inhibitors may increase the blood pressure reduction, and this actually may be therapeutically advantageous in most of the middle-aged patient, but in elder adults this can cause an acute blood pressure drop. Drug interactions are increasing as patients are prescribed more medicines. Again, they're increasing with polypharmacy. Prescribers can avoid the adverse consequences of drug and drug interactions by taking a careful drug history before prescribing additional drugs. Only prescribing drugs for clear indications These are the rules that we discussed previously. And taking special care when prescribing drugs with a narrow therapeutic index. When prescribing an interacting drug is unavoidable, good prescribers will seek further information and anticipate the potential risk. This will allow them to provide special warnings for the patient and arrange for monitoring either of the clinical effects, such as coagulation tests for warfarin, for example, or of plasma concentration, as an example, again, digoxin. And for clinicians, there are a lot of tools to check the drug interactions. One of them you can see on this slide. This is the website. This is a free website, drugs.com, where you can check the drug interactions of one, two, or several drugs just by writing the drug name in the box, and that's it. This is all information that I wanted to tell you in this lecture. Thank you very much for your attention.